Thank you very much. I am a Dane, though.
Oh, sorry.
No problem at all. But I moved to Sweden many years ago, which you might even hear on my accent in English. We'll see. So I was asked to talk about the management of children treated with recombinant human growth hormone or recombinant human IGF-I. One more common and one very less common treatment. And I had hoped that Alan would have introduced you a little further into the workup of these conditions, because I'm gonna mostly talk about when the decision has been taken to treat. And we had a question about who you can treat, and these are the indications that you can treat with growth hormone. So it's growth hormone deficiency, Turner syndrome, SHOX deficiency, Prader-Willi, which is a syndrome where the main goal to treat is more a metabolic goal to improve muscle strength and avoid obesity after this early period where the babies are very floppy. And I'm not gonna focus so much on that. SGA, which is one of the newest indications, which also includes some syndrome. Here is 2 kids with Silver-Russell syndrome, and ISS. And ISS is only an indication given by FDA. So in Europe, we cannot treat ISS patients, although we have done that in many studies throughout the years. Noonan syndrome is also an indication in the US, but Noonan patients have in some cases growth hormone deficiency and can be treated in Europe with that indication. Much less common is the treatment with IGF-I, and there's only one indication, severe primary IGF deficiency, that is defined here as a very short height, a very low IGF-I, growth hormone that is sufficiently secreted, and you have to exclude a lot of conditions such as nutritional deficiency, for example, which can cause growth hormone resistance, but it's a reversible condition. Here you see a number of Ecuadorian patients with a growth hormone receptor deficiency or defect that causes this condition, and you can see 2 healthy girls in the background. This is one of my patients with severe primary IGF-D or Laronde syndrome if there is a defect in the growth hormone receptor, and another signaling defect that can cause the same syndrome. But let's go back and look who is treated, and this is Swedish data with recombinant human IGF-I, and you can see the major proportion of patients are growth hormone deficient, isolated or idiopathic, some with slightly more severe growth hormone deficiency, and then a number of the other conditions that we talked about. So if we look at the more common of these diagnoses and the distribution among them, we can compare that with the KICS database. And now you get a little impression of how many patients that we treat. So this is close to 100,000 patients in this registry. And it includes patients from Europe, and you can see the distribution is very similar to Sweden, US, same thing, and Japan, slightly different with more IGHD patients. And now to IGF-I treatment, much less patients, 300 are registered in the database that has collected patients now for 10 years. And this is only European patients. There are patients in the Middle East and in South America and in other countries where this is more common. So in total, maybe there are a few thousand patients on treatment, but much less common than growth hormone treatment. You may look at these defects in the growth hormone IGF axis in a continuum, and all these are the conditions that we can treat with growth hormone. And the severe growth hormone deficient patients have the lowest secretion but the highest sensitivity, and I'll come back to this. And of course, patients with severe primary IGF-D with normal release of growth hormone are completely insensitive. So let's start with a case to try to highlight some of the problems in managing these patients. So this was a very young patient with an extremely low undetectable IGF-1 level and a rather low growth hormone secretion. He was faltering his height development at an early age, and you can see that he did not have SGA, but he had a relatively low birth length. And he also had a very short mother and a grandmother that was short. Now you can look at his appearance, and you can think about whether you will call his appearance symptomatic or not, and I will come back to this case a little later. But let's look at his growth chart a little closer. So we started this growth hormone deficient child, as we thought that was what we were dealing with a moderate dose of growth hormone. And as you can see, the development of height was not too great. We measured IGF-1 at several points, and the increase in IGF-1 was very moderate. And therefore, at that time, that is quite some years ago, we decided to increase his dose. And initially, that didn't help him much, but it looks like it may have increased his height velocity slightly later on. But when we evaluated him at 1 year, he had an increase in his height SDS of +0.5. And I'm not going to disclose to you whether this is considered good or bad. That is what I'm going to talk more about in the talk. Because the learning objectives, and you probably know that very well, is to understand the expected height response to these treatments, and that they varies a lot. To understand when and how to respond to a suboptimal height response to these treatments, and to understand the proper information to give to the parents prior to treatment, and that it's essential to calibrate expectations and facilitate appropriate actions depending on the response, the height response, and the side effects. So let me share with you some of the points that we are working on now in Swedish guidelines. And there are some points here that are, I think, new, and that kind of underlines these learning objectives. So first of all, during the workup, we have a paragraph to reconsider how far you should go in the workup in the endocrine clinic, because it's not very uncommon that we end up with patients that are fully biochemically worked up, and the testing is not very reproducible. So we might end up with patients that turns out to have low growth hormone secretion, but it's probably not a growth hormone deficient patient. And those patients we should really identify before we work them up fully. It's also important, we think, to consider the expected height response to treatment before we start treatment, because apart from the biochemical characteristics, there are other factors that impacts on their potential to respond to treatment, and that should also be considered before you come to the decision to treat. And this guidelines also has a paragraph about decision not to offer treatment, and that is something that we often forget in the endocrine clinic, to discuss with the patient why they do not fulfill the criteria to start treatment, and how we are planning to follow them. Sometimes they come back later on, and if they haven't had this explanation, it's going to be much more difficult to manage. Decision to offer growth hormone treatment should be followed by a very careful discussion with the patients and an informed consent of the treatment, so they fully understand what this treatment can offer the child and what kind of side effects that they may face. I'm not going to have time to go into the side effects and long-term effects, which is a whole symposium by itself. And finally, I'm going to focus on the choice of starting dose and the routines that should be taken when treatment is started. So let's look at the effects of treatment. And this is a huge cohort of US patients with their starting height and their final adult height. And you can see that although there is a significant improvement of height, perhaps around +2 standard deviations, many of these patients end up short anyway. And the median of their response is certainly under the mean height for the population. So this is important to understand when you start growth hormone treatment, that it's not necessarily going to normalize your growth. And most likely this is much closer to the target height that Alan was talking about. Now, this is a list of different diagnoses that have the indication to treat with growth hormone. And you can see that the responses varies from a very good response in very severe growth hormone deficient patients to a much less response in ISS. In this case, SGA, this article reported a pretty good response for SGA, which is not normally what you find, particularly if you exclude SGA-born patients that are growth hormone deficient. They will end much slower here, and I'll come back to that. But I also want you to realize that there's a huge variation within a single indication. So although you have an indication, you might have a very good response or poor response. So to try to compensate for this, when different diagnoses were approved for growth hormone treatment, the doses were chosen but to be higher in those with poor responses. But it doesn't fully compensate for this difference in responsiveness among the diagnoses. The dose range may be different for different brands of growth hormone, although it's the same indication or the same condition. And most conditions demonstrate a dose height response, not severe growth hormone deficiency, because it basically responds to any dose. It's most likely that a higher dose is going to give a faster catch up, but it's not completely clear whether it's also going to imply that the final height is going to be different. And we have some data to support that. And finally, there are differences between the Fdn and Ema indications. So in the US, there are about 50% higher doses used for the same indication. I'm going to talk a little about a study we did some 10 years ago, where the distribution among different diagnoses in the Nordic countries, about 500 patients that we identified with growth hormone treatment, was similar to what I've shown you before. And now I'm coming to the growth physiology of catch-up, and you can see that there is a age dependency on the growth responses to growth hormone, or the height responses to growth hormone. So at low age, there's a much better first year height velocity and a much better increase in height SDS. And that basically reflects what Alan went through in normal physiology, because height velocity is much higher in the younger than in the older prepubertal kid. And 1 SD equals 3 centimeters at 2 years, and much more, 6 centimeters at 11 years. And in a 2-year-old, catch-up increasing height velocity by 3 centimeters per year will cause a gain of 1 height SDS, but in an 11-year-old, the same height velocity only corresponds to half a standard deviation. So this matters when you evaluate the response of the child you are looking at. And when the indications were approved in the trials, the requirements from the authorities were usually height velocity increased by 2 centimeters per year. So let's look in some of the common diagnoses in the Nordic countries, and you can see that here SGA is actually the diagnosis that respond the worst, or has the poorest response. And it is in this study we took all SGA-born children that had a growth hormone deficiency. We classified them as growth hormone deficient. So if we looked in this group, there would be patients with SGA or AGA. And interesting, we found that they have the same response, and the response is as good as in the whole group and in ISS, but better than in SGA. So only those patients with SGA that are non-growth hormone deficient will have a poor response. We can also divide the growth hormone deficient patients into their peak growth hormone when they were worked up, and only those with a very good response had very low growth hormone secretion. So these are the severe growth hormone deficient patients that have the better response, and that is the reason why growth hormone deficiency usually do well in these comparisons. That is because of the very growth hormone deficient patient. So if we put these responses into a perspective in this cartoon, you can see that they overlap a lot, but with the highest average response in severe growth hormone deficiency. And of course, patients that are completely growth hormone resistant in severe primary IGFD do not respond at all. So in summary, I have talked about diagnosis as a factor that influences this variability, individual responsiveness, growth hormone dose, age at start of growth hormone treatment, and I haven't considered pubertal age, because if you start in puberty, the pubertal spurt will interfere with your response to growth hormone, and it's going to be impossible to really sort that out. And often in clinical trials, there is a better response than in real life. So how should we deal with this? So these are real life data from about 7,000 patients, and they have plotted the first year height velocity against the age at growth hormone start for a number of different diagnoses: growth hormone deficiency, ISS, organic growth hormone deficiency, often with other deficiencies, or could be cancer cases with brain tumors and so on, and Turner. And if we look a little closer, you can see the mean height velocity on growth hormone the first year, and the mean height velocity -1 ST. And that was suggested in this study to be a good cutoff for poor response. I'll come back to that. So even and that was US data I just showed. So this is European data, same amount of patients, but slightly different diagnosis. And you can see that they have not male-female. They have looked at first and second year catch-up. And there's no ISS patients because that's not an indication in Europe. They are SGA. So to give you impression of the difference between US with higher doses and Europe with 50% lower doses, you can overlay the KICS data with the US data, and you can see that there is a 2 centimeter per year advantage in catch-up if you use a higher dose. You can also see that if you use this cutoff that was suggested, it will fall right on the on the average in the European population. So that means that 50% of the European population would be poor responders if you use that that chart to evaluate. If you compare severe IGF deficiency with less severe, you'll see the same thing, that there's a much better responsiveness in the severe growth hormone deficient patients compared to the less severe, and SGA is going to look like this. So what we did was to express the poor responders by using different cutoffs. And here you see, for example, a cutoff with a height gain of less than 0.5 SDS. And you can remember that this corresponds to different number of centimeters at different ages. So if you use that cutoff, about 30% of the patients in the Nordic treatment study would have been poor responders, and about the same in the ISS population. So the poor responsiveness profile looks quite similar between idiopathic growth hormone deficiency and ISS. And the growth hormone deficient with organic reason would be responding the same. And some of these patients have irradiated spines, for example, and that will decrease their responsiveness. And SGA is definitely the diagnosis that has the poorest outcome. You may also use prediction models before you start treatment. And we looked in this material on the predicted growth response, and we compared that with the observed growth response. And we found that there's quite some patients that has false positive predictions. So they were predicted to have a poor response, but they actually responded very well, some extremely well, to standard deviation in 1 year. And there's also some individuals that were predicted to grow well but didn't do it. So predictions models are certainly not the full answer to whether you will respond or not. So given this complexity, what is the consensus of what growth, what cutoff we should use for poor response? And the answer is there is no. So age-related cutoffs for poor response is not very commonly used in Sweden. If the diagnosis specific data are used, those I just showed you, it may be that identical response will either be a poor response in one group of patients and a okay response in another. So for example, a Turner may have a response that is acceptable in the Turner curves, but it would not be acceptable for a growth hormone deficient patient. And that may not be very good. Comparison of observed and predicted responses from prediction models are not very accurate. So therefore, we have proposed that you could use a gain in height SDS of 0.5 as a cutoff for poor response. And in a recently published paper on guidelines of growth failure and growth hormone treatment, they suggested less than that. And 0.3 SDS is really not discriminating patients' normal variation in height over a year from whether there is a response or not. So we don't think that's a good idea. But at least you should evaluate the response, because that is a very important part of managing growth hormone treatment. So what about IGF-I? So that's a completely different story. These are the normal background population references. These are references for rhGH patients that has not been on treatment. And this is the indication study that was done. And you can see that these patients get a catch-up, but they don't reach into the normal population plus minus 2 SD. So these patients become very short, but much taller than they would have been without treatment. And these are boys and girls, and these are the data that we have from the EU registry. So we have previously reported that in IGF-I treatment, rhGH patients respond much better. But if we divide the non-rhGHs into responders, which is the majority of the patients, and poor responders, it's really the poor responders that drag down the response in this group. So you can easily have a good response to IGF-I treatment if you have severe primary IGFD, although you don't have a genetic diagnosis with a growth hormone receptor defect. And I think that's an important learning. And here we have used the cutoff of 0.3 SDS, because this is a completely different physiology of the IGF-I treatment. Here you see that even IGF-I treatment and responses are age dependent. So there are similarities between IGF-I responses, or rather responses to IGF treatment and growth hormone treatment. And we have reported that young age at start and short of stature is predictors of a good response. And in the indication studies, even dose was shown to be important. There are so much fewer patients with IGF-I treatment, so we are never gonna have the age-related response data that we saw from growth hormone treatment. And I just showed you that absence of genetic diagnosis does not exclude response to IGF treatment. So we have been through most of the learning objectives, but we haven't talked about how to respond to a suboptimal response. And now I'm back to IGF treatment, and it's common to start with a weight-based dosing at a moderate dose within the indication, like we did in the case that I showed you. And if there is a poor response to IGF-I, a poor short response, you should consider non-adherence or to increase the dose. And if you do increase the dose, it should be within the indication, which would not be the case in the patient I showed you, because there are limitations in what doses we can use. If height response is poor, and that can be evaluated perhaps after 6 months, perhaps you can get an indication after 3 months, then you should consider the same. You should use IGF-I as a safety marker and accept up to +2 SD in IGF-1, and perhaps a little higher during the catch-up phase. There's no evidence for this. We do not know exactly what IGF-1 levels means in terms of long-term risks yet. There are other safety markers that you might follow, for example, for insulin sensitivity. You should follow height and IGF-1, and if you read or change the dose, you should check the IGF-1 after dose change. So there are various strategies to dose without using a weight-based dose, and this is one alternative, that you could try to get a IGF-1 or a growth hormone dose that would give an IGF-1 at 0 SD or at 2 SD, and that is possible. This is a study from Cohen to do in 2 diagnoses, IGFD and ISS. And actually, you don't need to have very high doses to obtain 0 SD in neither of these groups, but they are not going to grow that well, the ISS patients. So if you get and aim at a higher dose, you will get an IGF-1 of +2, but you will run over the indications or the recommended doses for those indications. And if you do this, you can get a less variability in height response, but it's still there. So certainly there's not only a difference in responsibility to growth hormone, but also to IGF-1. And if we plot that into this diagram, you will see that the different diagnoses will have different sensitivities. And for example, SGA has a very poor IGF sensitivity, and that means that if you treat SGA patients, if they are not growth hormone deficient like these ones, they may have a quite normal IGF from the beginning, and if you treat them, they will run very high in their IGF levels, and that may not be well. So these are the non-growth hormone deficient. Another way to dose is to individualize the dose, and that will also give less variability in the response. But you can see that in this study, they use doses that are far higher than those that are approved by the authorities today. So this is not really possible. And always consider compliance or adherence, because that really matters for the growth response. So back to the case that we started out with. So this child, when we reevaluated the growth hormone curves, the overnight growth hormone curves, we saw that there was an elevated baseline. And when we looked at the mother and the grandmother, they had short arms, and we therefore did a array, and it turned out that these 2 boys, so there were 2 siblings, one I showed you, and this is the other sibling, had a deletion in STAT5B. So they are sort of Larong patients with a poor responsiveness to growth hormone. So we got the explanation why there was a much poorer response than what we expected. And now we have started these 2 children on IGF-1 as well. So we are through the learning objectives, and I just have to thank you for your attention.